Good day. My name is Kathleen Martin Ginis, and I'm a professor at the University of British Columbia in the Department of Medicine and in the School of Health and Exercise Sciences. I want to begin by acknowledging that I am recording this presentation from the University of British Columbia's Okanagan campus, which is located on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. Here are my disclosures. As with Hida and Kwok's presentation, much of the information in this presentation is drawn from our recent paper from the Lancet Physical Activity series. I would like to gratefully acknowledge my international team of co-authors and the research assistants who supported us. I'll be picking up from where Kwok and Hida left off to address why physical activity levels are so low in disability populations, the effectiveness of physical activity interventions, and evidence-based best practices for designing and implementing interventions in these populations. Why should you listen to this presentation? Well, if you're watching, presumably you care about people with disabilities, and the information in this presentation will help you support people with disabilities who want to become more physically active. And I also hope that this presentation might inspire some scientists. Our analysis of nearly 27,000 papers in the world's leading medical journals found just 0.3% addressed the health of people with disabilities, and just a handful of those focused on physical activity. As Hida noted, much more high quality research is needed on physical activity and disability. So why are physical activity levels so low in disability populations? This is largely a reflection of the tremendous barriers that people with disabilities face when they want to become physically active. In 2 meta-reviews of nearly 20 review papers on this topic, we identified 228 barriers and facilitators to physical activity. We categorized these into themes and situated them in a social ecological model. From this analysis, it's clear that children, youth, and adults with disabilities face extensive barriers to physical activity at all levels of a social ecological model and across both the healthcare and recreation sectors. An important caveat, though, is that we have almost no data from low and middle income countries, where I expect there are additional, more complex barriers. We also have very few studies testing which factors are the strongest determinants of physical activity, and here there is a need for theory-based research. But overall, the number and range of barriers attest to the need for multi-level approaches to intervention design and research. How effective are physical activity enhancing interventions? For our Lancet paper, we undertook a meta-review of meta-analyses testing the effects of physical activity enhancing interventions in children, youth, and adults with disabilities. We found just 9 meta-analyses in total, only 3 of which included studies with children. All of these interventions targeted factors at the interpersonal or intrapersonal levels, such as physical function, motivation, self-efficacy, or social support. 7 of the meta-analyses involved people with physical disabilities. Overall, these meta-analyses supported the effectiveness of the interventions, with a median effect size in the medium to large range of 0.64. We found only 2 meta-analyses of people with intellectual disabilities. These effect sizes were not as strong and were in the small to medium range. Overall, the research suggests that interventions targeting intrapersonal and interpersonal level factors can increase physical activity in people with disabilities. In general, the largest effects were for theory-based interventions that use behavior change techniques. But once again, we don't have any studies from low and middle income countries, and most of the studies have focused on a narrow range of disability populations and intervention types. In fact, none of the interventions in the meta-analyses tested interventions at the institutional, community, and policy levels, but there are some examples of these types of interventions in practice. For example, interventions or strategies that involve formulating guidelines for constructing accessible environments, for developing inclusive physical education programs. At the policy level, the development of policies to fund sport programs or to provide accessible transportation. Based on the existing evidence, we can formulate some best practices for designing and implementing physical activity enhancing interventions. The first question is, what should be included in those interventions? A few years ago, we reviewed and synthesized qualitative studies that reported on the experiences of people with disabilities who took part in an intervention designed to increase their physical activity. Our synthesis revealed 3 key themes. Study participants said that effective interventions provided evidence-based information on physical activity and how to self-manage their impairment or their condition. And while people want lots of information tailored to their specific condition, physical activity guidelines for people with disabilities are particularly important. People with disabilities and also parents of children with disabilities are often anxious about being active, and they don't know how to get started or what types or amounts of activity are appropriate. In addition, people working in gyms, rec centers, fitness facilities, they often don't know how to support a person with a disability to be physically active. Physical activity guidelines can help address some of these knowledge barriers. As Hida noted, the World Health Organization has developed generic disability guidelines, and there are also some specific disability-specific guidelines that have been developed for specific disabilities using disability-specific evidence, such as the spinal cord injury exercise guidelines and the multiple sclerosis guidelines, as I've shown here. The second theme that emerged in our review was that people with disabilities said that effective interventions provided them with training on behavioral strategies and techniques to manage their physical activity participation. Dr. Jasmine Ma and I published a meta-analysis a few years ago to test which behavior change techniques were most effective in physical activity interventions for people with physical disabilities. In the 24 RCTs that we found, over 30 different behavior change techniques were used. We looked at the effects on physical activity behavior for studies that used a particular technique versus those that did not use that technique. We found that interventions that used self-monitoring, that provided behavioral feedback, that gave people behavioral instruction, and that taught them how to solve problems resulted in greater improvements in physical activity than interventions that did not include those techniques. And so we would definitely recommend including these techniques in interventions. Interestingly, in studies where participants' behavior was monitored by others, but they didn't receive any feedback on their behavior, in these interventions, behavior change was significantly less than in studies that did not use that intervention technique. So this is a technique that we would not recommend using. The third theme emphasized the importance of social support from health and fitness professionals. And I think this quote sums up that perspective nicely. Having a person who can actually give recommendations on fitness activities with the knowledge of my condition or disability is very helpful and not easy to come by in the gyms or anywhere else where people have any clue or can give advice. The next question is, who should deliver physical activity enhancing interventions? We know from considerable research that people with disabilities want to get their information from their healthcare providers, and lots of different types of healthcare providers are seen as valued and reliable sources of information. Family doctors, specialists, kinesiologists, physiotherapists, nurses, and so on, all are considered reliable sources of information. People with disabilities also want to receive physical activity information and interventions from their peers, as this quote describes. Other people that have done the activity and can tell you from a person that is disabled what it's like to do that activity and what it involves. I mean, I think that speaks volumes to somebody with an injury to hear that. It is helpful. The next question is, how should activity enhancing interventions be developed? Historically, behavioral interventions have often been ineffective, and they have often been criticized for being developed using an approach that has been labeled as Islagiat, or seemed like a good idea at the time. In contrast, Campbell and colleagues have provided a framework of steps for developing complex health interventions that I think applies very well to physical activity intervention design for people with disabilities. These steps involve first identifying an appropriate theoretical framework to guide the design of the intervention, to engage end users of the intervention throughout the entire design and research process, to pilot test, and not just for the feasibility of the intervention of itself, but also to pilot test the measures that will be used to evaluate the outcomes of the trial. Then an RCT can be conducted to test the intervention's efficacy, and from there, the intervention can be more widely implemented. And I can't overemphasize the importance of using theory to guide intervention design. Our meta-analysis showed the average effect size for theory-based interventions was 4 times the effect size for interventions designed without a theory. I'd like to give an example from my lab of how we use this approach to co-develop and test the effects of a behavioral physical activity interventions for adults living with spinal cord injury. Using Campbell and colleagues' framework, we spent nearly 2 years on the intervention development, completing systematic reviews and compiling an evidence base to inform the selection of a theoretical framework for the intervention. We also engaged over 300 end users, that is, people living with spinal cord injury, those in their family who support them, and also physiotherapists, i.e. the people who would be delivering the intervention. We engaged them throughout the entire process as well. We conducted a national survey and expert panel meetings, and we spent a lot of time on piloting and choosing an appropriate measure of physical activity, because physical activity measurement in people who use wheelchairs is complicated. From there, we developed an intervention prototype. So this is actually a 50-page manual designed for physiotherapists to use with their spinal cord injured clients. In a nutshell, the physiotherapists are taught to gather information on their clients' physical activity barriers and facilitators, to then teach them the spinal cord injury exercise guidelines, to create an individualized, tailored intervention that involves behavior change techniques, referrals to community resources, and providing a tailored exercise prescription. The intervention is delivered as an 8-week intervention consisting of a 1-hour initial assessment and followed by 8 15-minute counseling sessions. We first piloted the intervention with physiotherapists to ensure its feasibility, and then conducted an 8-week randomized controlled trial of the intervention involving 30 adults with spinal cord injury. The intervention was framed in Schwarzer's health action process approach model. Looking at the effects on psychosocial predictors of physical activity, we found that over 8 weeks, the intervention condition had significant improvements in self-efficacy, social support, and self-regulation for exercise relative to the control group. Looking at the effects on physical activity and fitness, from pre to post-intervention, we found a 5-fold increase in both self-reported and accelerometry measured moderate to vigorous intensity physical activity for the intervention versus the control group, and significant improvements in aerobic fitness for the intervention versus control group. This intervention produced the largest effects found of any physical activity behavioral intervention involving people with a disability, and was the first spinal cord injury behavioral intervention to show significant effects on fitness. Importantly, the increases were sustained over a 6-month follow-up. Following this intervention, we spent some time to sit back, to talk with participants, and really try to understand what made the intervention so effective so that we could replicate this in the community in the future. And I think it all boils down to the intervention being both theory and evidence-based, to our engagement of over 300 end users in the intervention and testing processes, and that the intervention itself was highly tailored and responsive to participants' varying exercise barriers, needs, and motives. As Hidden mentioned, the disability population is tremendously heterogeneous, and I don't think we should be expecting one-size-fits-all solutions. We are now implementing this intervention in the province of British Columbia through both our province's rehabilitation hospital and in the community through our partnership with Spinal Cord Injury British Columbia. So to wrap up, I'd like to leave you with a few ideas on how we can do better in terms of developing physical activity interventions for people with disabilities. First, I think greater efforts are needed to design, implement, and evaluate multi-level interventions to alleviate systemic barriers. Second, we must shift the research focus from merely describing barriers and facilitators to identifying and intervening on the strongest determinants of physical activity. And third, we must collaborate with end users to develop tailored evidence and theory-based interventions that meet users' needs. With that, I'd like to acknowledge the team members, community partners, and funders who have supported this research. And here's my contact information. Thank you very much for your attention.